Good evening, ladies and gentlemen. Welcome to this ward rounds. As you're all aware, ward rounds is basically dealing with issues that people face in the wards. All right. So while it includes pre-op workup and post-op care, most of the focus is on post-op care because after you have operated on the patients, we would like the budding surgeons, the trainee surgeons to know what kind of problems one faces, what are the problems that you should be looking out for when you do your rounds, and finally, things like drains, IV fluids. When do you discontinue? When do you put it in? What kind of a drain would you put in? What are its advantages? And discussion like that. And it may also include how and when do you recognize deterioration in a patient, in a post-operative patient, and what actions do you take? And so it is done on, it's not purely theoretical. There is some theory behind it, but it's a lot more practice oriented. And you look at the cases in your ward. In a real life situation, you actually take a ward with your teacher, take a ward round, actually see the patients, come up with all the findings. But here, because we can't do a physical round, we will have these findings that will be provided by our students, and then we will take up the discussion. And it is really an open discussion where I probably would act only as a moderator. Obviously, I'll give my views in, but every one of you, students and teachers, would actively participate, and there will be a collective learning. Over to you, Ajit. I think you are giving the cases, and as I said, ravishankar is held up for a bit, and as soon as he joins, he will take over as the moderator. Go ahead, Ajit.
Thank you, sir. Good evening, everyone. In today's ward rounds, we have two cases to discuss. One is CS stomach, and the other is CS sigmoid colon. So this case is a 63-year-old gentleman who was admitted under a physician, and then the surgeons were given a reference. So he's a chronic smoker since 40 years, and known case of diabetes mellitus and ischemic heart disease. He had undergone PTCA in 2018, and is on dual platelet agents, ticagrelor and aspirin. He came to the emergency with complaints of pain abdomen, dyspeptic symptoms, melena, and weakness since 2 months. He was also complaining of increased urinary frequency and has lost around 4 kgs of weight in 2 months, and also complaints of decreased appetite.
Just one sec, Ajit. Ravi is here. Ravi, welcome to the program. We have started, and we just literally on the first slide. You have missed nothing at all. Please take over.
Thank you, sir. Thank you. I got stuck in the OT, and then there is a problem with metro.
No problem. Just take over. Yeah. Please continue, Ajit. Yeah.
Okay, sir. Just to
I can see.
Ravishankar. Yes, sir.
Yeah, continue, Ajit.
Yes. So he was investigated first. He was found to be anemic. Peripheral smear showed microcytic hypochromic anemia. We got his RT-PCR done, which is a protocol, and it was negative. Renal function and liver function tests were normal. His blood group was AB positive. I just want to ask Pawan, what is the significance of blood group in the case which we are discussing? Pawan?
Sir, am I hearing? Hello, sir.
Ajit, yes, I think it is not clear.
Okay, hello, sir.
Okay, sir. So since he was he had coronary artery disease, we got 2D echo done, and it was normal. Since he had urinary frequency, we got his serum PSA done, which was also normal. So upper GI endoscopy was done for evaluation of melena as well as anemia, and it showed large ulcer in the lesser curvature of stomach and ulceroproliferative lesion with bleeding in the greater curvature. So there was bleeding, and they could not, they were not able to take a biopsy. So repeat endoscopy was done, and biopsy was taken. Here we can see ulceroproliferative lesion around the greater curvature and the body of the stomach. So they were the gastroenterologist told us that it probably may be malignant, and so contrast intensity of the abdomen was done, which showed a growth along the distal body as well as antrum of the stomach. Here you can see. He also had cholelithiasis and mild prostatomegaly. So there was this circumferential wall thickening in the distal body and antral region, involving lesser and greater curvature, extending for a length of around approximately 6.6 centimeter, and it had maximum wall thickness around 16 mm. And there was a serosal infiltration with periserosal involvement. There were multiple enlarged perigastric lymph nodes, and mild prostatomegaly and cholelithiasis as explained. There was calculus measuring 5 mm, however no pericholecystic collection. So the biopsy turned out to be moderately differentiated adenocarcinoma, and he was planned for exploratory laparotomy plus radical subtotal gastrectomy plus proceed after correction of anemia and open cholecystectomy. Before operating, we got a urologist opinion who suggested ultrasound KUB.
Ajit, I think
Yes,
basically we needed a small case capsule about what the patient had. You are explaining everything. I think it's ward rounds is more about patients who have already been admitted, who have had surgery or about to have surgery, and such people. So I think there is no need for you to elaborate on all these things.
okay, sir.
So you tell me what did they do on the table?
Sir, they did exploratory laparotomy plus radical subtotal gastrectomy, sir, plus gastrojejunostomy, plus jejunostomy and open cholecystectomy, sir.
Okay.
I have the intra pictures, sir.
Yeah, can you briefly describe what is entailed in a distal gastrectomy?
Sir, distal gastrectomy basically is done for tumors in the distal part of the body and pylorus and antrum, sir. So, should I describe the steps of the surgery or, sir?
Yeah, what are the types of gastrectomy you know?
Sir, D1 gastrectomy, D2 gastrectomy,
No,
sir.
no, that is
Then
D1, D2. D1, D2 is this one. But
for
what
lymph
there are,
nodes.
no, those are lymph node this one. What is the
The
types of gastrectomy?
total and partials.
Partial, total, subtotal, sir.
Total gastrectomy, partial, but then the most important thing I want to know is whether you know about the Billroth 1 and 2 gastrectomy.
Yes, sir.
Tell
Billroth
me
1
what
is
yeah.
gastroduodenostomy, and Billroth 2 will be gastrojejunostomy, sir.
Okay. So describe briefly what are the steps of gastrectomy.
Sir,
where do you start?
Yes, sir. Sir, in patient under general anesthesia, after painting and draping, midline incision will be given from zipisternum to about halfway between umbilicus and symphysis pubis.
I think you may not need to go beyond umbilicus. Okay. Why do you need to go beyond umbilicus?
Up to, sir, look for...
If you need, you can extend it. But usually the upper midline incision is sufficient. You don't need to get into trouble by saying incision beyond umbilicus.
Okay, sir. So up to umbilicus, sir. Then incision is deepened in layers. Then assessment is done for after opening the peritoneum. Assessment is done to see for liver mets, peritoneal mets, sir. Then
what else do you look for?
Then ascites.
Ascites, yes.
Yes, sir. Lymph nodes. Then fixity to pancreas, spleen, or colon, transverse colon of the tumor.
Contiguous spread, yeah.
Yes, sir.
What makes it inoperable?
Sir, inoperability is peritoneal mets, sir. Peritoneal mets, liver mets, ascites, and spread to adjacent organs like, as I mentioned, pancreas, transverse colon, or spleen.
Fixity to transverse colon does not make it inoperable because you can resect it along with it. When you can remove a contiguous organ, for example, pancreas, maybe I agree, because
yes,
that will mean a very major resection, and again you don't know whether it is actually going to be clinically effective, because then you have to assess about Whipple's resection and then its complications thereof. So pancreas, maybe I agree, but colon, I don't think. Spleen also, I don't think usually if a spleen, for example, tumors arising from the lesser curve and pylorus will not be attached to the spleen anyway, so spleen will not be a problem. But transverse colon, if it is, then you can actually resect it.
No, we'll go.
Okay. Continue.
Sir, hello. Hello. Sir.
Yeah, Dr. Shivram asks, what is the pre-op albumin of this patient?
Sir, 6.3, sir.
You can't have an albumin.
So, sorry. Not.
That is total
sir,
protein.
3.3, sir.
Is there any cutoff beyond which you don't operate?
Sir, less than 3, I think.
Yeah. Less than 3, you build up the patient. What happens if you have albumin less than 3?
Hypoprotein.
What does albumin of less than 3 indicate to you?
No wound healing, sir. Wound healing.
It indicates general malnutrition. General undernutrition. It is just a reflection of the general nutritional status of the patient. So there can be anastomotic leaks and wound infections and other complications related to malnutrition. Okay, continue.
Saurav wanted to ask something.
Yeah, sir. So even so for the Japanese, sir, for distal pancreatectomy is also considered operable only, sir.
No, I didn't say distal pancreatectomy. We are talking about not a hypothetical situation. We are talking about this patient. Where will you have distal pancreas involved in this patient? Tell me. See, this is a tumor in the pylorus, so it can't have involved if at all it is involved, it would involve the head and uncinate process. So
yes, true, sir.
Inoperable. That's what I meant. Dr. Lakshman, sir, can you want to come in, sir? There was a comment. Dr. Lakshman?
Can you hear me now?
Yes, sir.
Yeah. I wanted to make the point that inoperability does not mean you will close the abdomen and come out.
Correct.
Just because there is involvement of the pancreas probably yes, head of the pancreas particularly, or the colon or the spleen. What you have to also take into account is the condition of the patient. Is there outflow obstruction? Then you have to do something. And it may in fact be a palliative resection where you dissect the tumor of the pancreas. You may leave some tumor behind, but you resect the tumor of the pancreas and give them a palliative partial gastrectomy than a curative one. So the inoperability is a relative term, and that's the point I wanted to make.
No, I meant inoperability with an intention to cure.
Yes, that is the definition.
Yeah. That's right. Right, Ajit. What are the vessels you ligate when you're doing a distal gastrectomy?
Sir, right gastroepiploic vessel, sir. Then
come on, quick, Saurav.
Right gastric, sir, and left.
So the right and left gastric and the right gastroepiploic vessel, sir.
Okay. What about the gastroduodenal? Do you have to do anything with the gastroduodenal?
Yes, sir. We have to ligate that also, sir.
No, not the trunk of the gastroduodenal. You may have to ligate the gastric branch of the gastroduodenal artery. The ones which goes up. Because the superior pancreaticoduodenal vessels arise from the gastroduodenal. So you may not have to, unless it is infiltrating it. But then if it is infiltrating, then it becomes a very difficult operation anyway. Okay. So the left gastric, the right gastric, and the two gastroepiploic vessels are ligated, but you don't touch the short gastric vessels because you want to preserve the fundus in this case.
Yes, sir.
Yes, sir.
So Ajit, can you tell me, in this case they have done a gastrojejunostomy and a jejunojejunostomy.
Yes, sir.
Is that a better drainage procedure compared to a Roux-en-Y? If so, why? What is the difference between Roux-en-Y and a straight gastrojejunostomy? Do you know or you don't know?
Sir, in gastrojejunostomy, we will connect only because to prevent acid reflux, the bile reflux, sir, it is better to get Roux-en-Y, sir.
Is that the only advantage? Anybody? Abdul, are you there? Abdul is not there, I think. Saurabh?
Sir,
Sir, it is end to side, sir. I'm there, sir. Sir, hello.
Abdul, I think you are the person to answer this question. What is the advantage of a Roux-en-Y gastrojejunostomy compared to a straight gastrojejunostomy with jejunojejunostomy?
End to side anastomosis, less reflux.
Yeah. I think the major advantage is bile reflux. So there is no minimal bile reflux with the Roux-en-Y, but also you have the afferent and efferent loop obstructions and gastric stasis, which are all problems associated with the straight gastrojejunostomy as opposed to a Roux-en-Y. Dr. Shivaram, is there anything you want to add to this point?
Yeah, I was little worried how this patient was optimized before surgery. Is it okay to ask that question, or shall we stick
Yeah,
on
of
only?
course. Yeah.
Sir, we started him on as soon as we got a reference. We started him on incentive spirometry, sir, to improve his lung function, chest and limb physiotherapy, as well as he was optimized with the blood transfusion. So once the HB reached 12, that time we had taken him for surgery.
Right, because he is a chronic smoker.
Yes, sir.
He is,
actually, sir, I forgot to mention one thing. When he got PTCA done, that time the cardiologist has advised him to stop smoking. So since last 2 years, he has not smoked. But before that, he had smoked for 40 years, 1 pack per day. So,
right. That's
yeah.
good. Yeah. And also anything neoadjuvant treatment for him was considered because his cirrhosis was involved, lymph nodes were involved.
Sir, we have not given anything neoadjuvant, sir.
Yeah. All right. Carry on.
Shivaram, specifically about the gastrojejunostomy, they did a straight gastrojejunostomy and a jejunojejunostomy. Is that your preferred mode of reconstruction, or would you prefer to use Roux-en-Y gastrojejunostomy?
No, Roux-en-Y is always better than the loop gastrojejunostomy and jejunojejunostomy. That's what you are telling, no?
Yeah.
Loop, yeah, okay. Roux-en-Y is a preferred method. Yes,
Lakshman,
definitely.
sir?
Yeah, both are, studies have shown that both are equivalent. The surgeon's choice.
Okay, but don't you think the afferent loop obstruction and then stasis and all these things are more with the the loop gastrojejunostomy?
It is not borne out in theoretically. It is true that when you have an afferent loop, it can get obstructed, but it has not been borne out in studies. Any kind of drainage is equivalent. What should be avoided in gastric cancer is a Billroth 1. You do not do a gastroduodenostomy,
yeah,
because local recurrence there can block up can cause stenosis of your anastomosis. Yeah. But in a Billroth 2, also called polya, you can do either Luan or do a loop with. It's always preferable to get a jejunoctomy further away from the gastrojejunectomy, so that you don't have too much bile reflux. That is a recommended procedure.
Yeah. Niranjan?
Sir, actually he was traveling somewhere. That's why.
Okay. Srikanth is there? Okay. Ajit, can you outline all the measures that you take to pre-optimize these patients?
Sir, first, as we discussed, if the patient is smoking, then it should be stopped minimum one month before surgery. Yeah. Then his lung function has to be assessed, because he was chronic smoker, and it has to be optimized by giving incentive spirometry as well as chest and limb physiotherapy.
Okay.
Then his anemia has to be corrected, sir.
Is there any role to correct anemia preoperatively? Is it going to benefit? Is there any immunologic phenomena related to blood transfusion?
Sir, actually they say that after blood, you should not give blood transfusion before the surgery. It will increase the chances of recurrence.
But that is why I wanted you say that, yes, so that we could. I think there was fear before that, yes, preoperative blood transfusion caused immunologic interference, and that would lead to recurrence. But that theory has been now disproved. I don't think there is any proof, evidence to show that. But I think the main thing is you should know if a patient is hemoglobin is 8 and he has no comorbidities, that is sufficient. But you need to have blood in reserve for post-operative transfusion if required. And if the patient has cardiac illness, then you need to have a blood of 10. In patients, yes, who have got cardiac illness, you need to have a hemoglobin of 10. Yes. And if at all you have to transfuse blood, I think this is for the first year PGs. If you have to transfuse blood, how soon you need to give the blood before you operate on this patient? Janani, is Hari there or Hari not there today?
Sir, Hari told me that he has network issues in his village.
Right. Hello, sir.
Yeah, he's there. Yeah.
Audible, sir. Hello.
Janani.
Sir, I didn't hear your question properly. Hello, sir.
How soon do you need to transfuse before you operate on these patients, if at all you have to transfuse?
Sir, at least 1 or 2 days before surgery, sir, if it is not for emergency case.
1 or 2. You have to give me a specific answer. Why do you need to transfuse earlier? What is the reason?
Sir, because the 1 unit, if we give it, takes up at least 24 hours to the hemoglobin to rise, sir, to active.
No. That is not the answer. Janani?
Sir, am I audible, sir?
Yeah. Janani, you are not audible. Ajit, okay, you take that question.
Sir, 2 to 3 days. I'm not sure, sir.
It has to be at least 48 to 72 hours. What the reason for that is? See, you need the oxygen dissociation curve to shift to the right, and that takes about 48 to 72 hours. So no point transfusing the day before surgery. So if you have to transfuse, as we said, the rule of the thumb is in patients who have no comorbidities, a hemoglobin of 8 is acceptable. In patients with cardiac comorbidities, in a hemoglobin of 10 is acceptable. And if you have to transfuse for that reason, you should transfuse at least 2 to 3 days before surgery, preferably 3 days, so that it is the blood that you have transfused is beneficial. Okay. Continue, Ajit. So this patient whom you have operated, you have done a total, partial gastrectomy and gastrojejunectomy and jejunojejunectomy. So how do you manage this patient post-operatively?
Ravi, can I ask a question?
Yes, sir. Yes, sir.
No. Why it takes so much time for this curve to improve? No, because intra-op transfusion or one day before transfusion, we see so many cases, or many gynecologists, they give blood transfusions morning and then operate. So, because I also didn't know about it, what you are telling.
Sir, I see the thing is, what is practiced and what should be done is different. But definitively, I know, and I don't give much credence to what gynecologists do, because I don't think they practice much evidence-based medicine, to be honest. But basically, the 2,3 DPG, which is what is crucial in the oxygen dissociation curve, that needs to be, that is one which shifts the curve to the right, which helps the dissociation of, distribution of oxygen to the peripheral tissue. So that takes about 48 hours. So basically it starts at 24 to 48 hours. So preferably you transfuse them before 2 to 3 days before you operate. But intraoperative blood transfusion is a different thing, because that is required because the patient blood pressure is low. There is probably hemorrhage and you have to transfuse. And that, again, the effect of that will be seen later only.
Yes.
Right.
I think it to increase the preload, sir, in intraoperatively.
Right. So now, Dr. Lakshman sir, is there anything else you want to add to the thing?
No, I think that's right. Stored blood gets depleted in its 2,3 DPG, and so it has to be in the body at least for 24 hours for it to be replenished. And only after 2,3 DPG is replenished does the hemoglobin give up its oxygen. Otherwise, the hemoglobin dissociation curve will be pushed to the left, and it has to be again pushed back to the right for it to give up the oxygen radicals. 24 is a minimum, preferably 48 is what I would agree.
Yeah.
And please understand, blood transfusion is given in this situation for oxygenation only. It is not for blood volume. What is given on the table is to replace the blood volume.
Blood volume, yes.
And sir, autologous blood transfusion, so we can, to avoid that immunologic response.
Yeah.
So can we can give
definitely, if it is possible, the thing is, if you are see, the thing is, the autologous transfusion is only when you, for example, it used to be common practice in cardiac surgery because they would go on pump, but now they are usually not going on pump because they are doing beating heart. So I think even in cardiac surgery they don't use it that much, but in patients whom you expect a lot of blood loss during surgery, and their pre-op hemoglobin is 12 or 13 or 14. So you can take 2 to 3 units of blood about a week, 1 week before, and then 3 days after that. So you have, basically autologous blood, and then you can use that. Again, I think they are fractionated and you use the packed cells rather than the whole blood. I think whole blood transfusion by and large is given up, but sometimes probably it has a role. Okay, so this patient you have operated, the surgery is done. So how do you manage this patient? Tell me the chronology of events.
Sir, first patient has to be kept NPO, then started on IV fluids.
Right?
Sir,
have you not heard of enhanced
yes,
recovery?
Enhanced, sir, till
hello?
Yes, sir. According to ERA's protocol, we can start feeding early, sir. But
Early meaning when?
After 24 hours.
No. Immediately. Once the patient is fully conscious and alert, you can start allowing oral sips of sips of clear fluids, and then tell me what else do you do? What are the things you watch for?
Urine output, sir.
Okay.
Vitals.
What?
Urine output should be around 0.5 ml per kg body weight of the patient per hour.
What? Why do you need so much? 1.5 is too much.
No, 0.5, sir. 0.5, 0.5.
Yeah, 0.5.
Yes, sir.
What happens in the first 24 to 48 hours of surgery? What are the hormones that are active and reduces your urine output, which is why you should not chase urine output?
Antidiuretic hormone, sir.
ADH, mainly ADH.
Yes.
So urine output is one thing. What else do you look for?
Vitals, sir.
Vitals.
Yes.
No,
then
you should
you have to
elaborate on vitals. What are the things you look for? Do you
pulse.
Do you nurse this patient in a post-operative ICU or?
Yes, sir. He has to be kept in observation in a post-surgical ICU. Then pulse, you should make sure that the BP is controlled, because in case of uncontrolled BP, there may be suture line hematoma or bleeding at the operated site. Then we have to watch for tachycardia. If the patient is bleeding intraoperatively, it is a sign which shows that the patient might be bleeding inside.
So between Dr. Lakshman asked, between pulse and blood pressure, which is more reliable?
Pulse.
No.
Pulse.
No. If the patient is in pain, if the patient has temperature, even then the pulse rate can go up.
Yes.
But the blood pressure is much more, much more of a reliable indicator, of the patient's condition. Isn't that right?
Yes.
Gaurav?
Yes, sir. Yes, sir.
No. I have a slightly different view in this. Taking that patient's pain is well controlled.
Yeah.
Okay, that is a given in these days of good post-op care. Tachycardia is a sensitive indicator of hypovolemia. So even before the BP falls in a post-op patient, I think we should be focused very clearly on the pulse rate. If it is above 100, one of the first things that you do is make sure that the patient has no pain. And if he still has a high pulse rate, even before the BP falls, your antenna must go up for a possible hemorrhage. And of course, Ramakrishna makes a very valid point that pain can increase the BP also. Okay, and so I think we should first make sure that the patient is not in pain, and once that condition is satisfied, pulse is a more sensitive indicator than a BP.
Okay, Ajit.
Yes, sir.
So you started oral fluids. What are the things that makes you worried that something is wrong in this patient?
Sir, if the patient is not conscious, disoriented patient, then per abdomen, if there is guarding rigidity kind of thing, or there is distension of the abdomen.
Before all that, as I think Dr. Lakshman just now told you.
Tachycardia, sir. Vitals we should have to.
So tachycardia. So tachycardia is the one which is, you have to be tachycardia, hypotension, and then oxygen saturation. Oxygen saturation, and more importantly, as we said, mean arterial pressure more than the blood pressure itself. Mean arterial pressure is a much better indicator. And then and then you obviously if the abdomen is distending and things, or if you have placed a drain, if the drain output shows that it's blood. So these are the things which make you worried. So what is that you are worried about in the first 24 hours? Mainly?
For sir, since this patient is a cardiac patient, we have to start him early on Clexane or some blood thinners.
So for that, you have to be sure that there is no
intra
hemorrhage.
bleed. Yeah, hemostasis should be satisfactory before closing, sir.
Okay. So in the first 24 to 48 hours, you are more worried about the bleeding. Subsequently,
yes.
other things can happen.
Drain, yeah.
So, and what are how do you then continue the care of this patient? Let us say he's been steady, he's stable,
Yes.
his vital parameters are normal. And do you put a nasogastric tube in this patient or not?
Sir, we have to put, sir, nasogastric for 1 day at least till we start the feeding. Once we have started the feeding, then.
Sir, I think that nasogastric tube is a bit of a surgeon's choice, sir. You can put, we may not put also, sir.
I think I agree with you, but the studies have, the ERAS protocol has shown that nasogastric tube is not necessary even in upper GI surgery. So
yes,
generally it is not not necessary to put a nasogastric tube. It is not necessary to place any drain, and it is also important to start feeding early. The
early, yes,
most
sir.
important thing is analgesia. You have to give them adequate analgesia so that they are
Yes.
mobile. You mobilize the patient early and then allow the patient to have oral feeds, which is increased in a graduated fashion as and how the patient tolerates it.
Yes.
Okay.
We can give epidural analgesia, sir, for pain
Epidural
control.
analgesia will help early mobilization. Again,
Yes.
there are pros and cons of epidural analgesia, but by and large, it is. I think a lot of people, again, are not very keen on giving epidural, but I think epidural is definitely part of the ERAS protocol.
Yes. Sir, because of hypotension, sir.
Because of hypotension, and I think somehow some people are very against giving epidural.
Yes.
Okay, then. So what are the other problems that you anticipate in this patient as you go along? I've told you that patient is doing reasonably well. What
Yes.
are the things you expect in the next 48 to 72 hours?
Sir, we have to ambulate the patient early, otherwise there is a risk of DVT, sir. Otherwise, if a patient is not ambulating, we can give a Clexane. And
not just Clexane, you have to thromboembolic deterrent stockings. And
yes,
if the patient is
Pneumatic
high risk,
compression.
you have to give them
pneumatic
compression.
Hot stop.
You have to stratify the risk of deep vein thrombosis. So this patient is elderly. He is had surgery for malignancy. He is a smoker. So he will fall in the high risk category. So you have, and he has had previous cardiac surgery also. So he will need to be given this one compression stockings if he is not ambulating. Definitely this one pneumatic compression device. If again one of the things, and then Clexane as well.
Yes.
So I think the Riles tube aspiration, if the Riles tube is present, and urine output, and obviously total input output chart. These are the things you should all mention these things automatically as you are analyzing or monitoring this patient. What about chest?
Chest limb physiotherapy, sir, as well as incentive spirometry, which we had started previously only before the surgery. It has to be continued after the and the patient has to be counseled, because sometimes the patient will not be cooperative. They have to be counseled properly regarding the spirometry.
No, that is what the preoperative spirometry is. That is the purpose. So you teach them how to do it. You give them chest physiotherapy. You teach them incentive spirometry, and you should make sure that every time you do a ward round, you instruct your residents also that every time they go and see the patient, they should make the patient do it. You should also instruct the nurses and the attenders who are sitting with the patient to do this thing on a regular basis.
Yes.
Because I think that is very important. So when will you allow the patient a soft diet? And
sir, if the patient is tolerating well, We can, yeah, we can start, sir.
Okay.
And appetite, sir, he should have appetite. If the patient is feeling hungry, we can allow.
Okay. And in terms of the abdominal examination, anything that makes you feel that we should be a
Sir,
bit
he should pass after passing flatus, sir.
generally when do the patients usually pass flatus after upper GI surgery?
3 to 4 days, sir.
Slightly earlier than that, maybe, but I think, yeah, 3 to 4 days is fairly reasonable to accept. So I think the main thing is the patient should be progressing in a normal fashion. I think all the protocols and things are fine, but I think all these things have to be tailored to the patient's
Yeah.
condition and patient's response. If the patient is very distended and he is, having hiccups or feeling nauseated, there is no point trying to progress onto soft diet and things. You just need to come back a little and allow the patient to settle down, allow the patient to recover and improve, and then you can. So it's not as if on the third day we have to feed them. If the patient is progressing, of course, there is no restriction. You can allow the oral diet.
Yes.
When would you expect to discharge this patient?
Sir, if we follow ERA's protocol, then we can send the patient home early around fifth post-operative day. But
Actually,
sir,
it is 3 to 5 days, provided the patient is pain-free or his pain is well controlled with the routine analgesia. The patient is mobilizing, the patient is tolerating oral diet and vital signs and things. There is no temperature, the wound looks clean, and if the progress is good, between 3 and 5 days, you can discharge this patient.
yes.
What are the now you've done the some gastrectomy, and about three to four nodes out of all the 15-20 nodes that you've removed has come positive, but the margins are clear. So what is the next line of treatment in these patients? And if you are going to give anything, what are you going to give?
Sir, you said 3 to 4, no, sir? So it will. Hello.
Tell me.
It will come in stage 2, sir, because stage N1 is 1 to 2, N2 is 3 to 6.
Yeah.
3A is 7 to 15, and 3B is 16 or more. So in this patient, we got around 12 nodes positive along the greater curvature and 7. So he falls in the category 3B, sir, and 3B.
Yeah.
So, and since there was extension, the tumor was invading the serosa, and there was a lymphatic perineural invasion. So he falls T4A. So that is invasion of serosa as well as involvement of 12 plus 7, 19 lymph nodes. So stage 3, sir, this patient falls in.
What is the prognosis?
Prognosis, sir, usually 5-year survival in India for operable gastrectomy is around 20%, sir. It is very less as compared to Japan, where it is around 70 to 90%.
No. I think that is 70 to 90% is only for early
gastric cancer.
Early gastric cancer. Yes.
Yeah. So I'm asking about this patient.
So 20% 5-year survival, sir. 20.
Even that is too much, I think, because there is serosal involvement, there is significant lymph nodal involvement. I think maybe anywhere between 10 and 15% is probably the 5-year survival.
So he will require post-operative chemotherapy, sir.
Yeah.
Yes, sir.
What chemotherapy usually? What is the current chemotherapy that is given?
Sir, that is the combination, sir, of cisplatin, epirubicin, and 5-fluorouracil.
Yeah.
And sir, we can also ask for the markers, sir, for HER2 markers.
Yeah.
And because this is a case advanced gastric cancer, if HER2 is positive, we may consider trastuzumab, sir.
Yeah, giving Herceptin or trastuzumab. Yeah. See, is there generally Vasant asked a question. Vasant, you want to come in with that question? I didn't ask about anastomotic leak because we usually don't expect gastrojejunostomies to leak.
Yes.
Vasant?
So particularly in Bilrod 2, sir, in this case, we may expect duodenal stump leak, sir.
Stump leak, yeah.
Day 4.
When does it usually happen?
Sir, day 4 to 5, sir.
Duodenal stump blowout, yeah.
Yes, sir.
How do you manage a duodenal stump blowout? Saurabh, now that you have said it.
Sir, so once we feel that there is some bloat, we'll confirm it radiologically, and we can put a Foley's to the
no, monitor drain output, sir.
Drain, you have to monitor, see the white.
Okay. See, the problem is many times you don't expect anything to happen, so you wouldn't have put a drain also.
Yes, sir.
So that is the problem. If you haven't put a drain, how will you manage this patient?
So we can we can make a duodenostomy and put a Foley's there, sir, after opening, sir.
Radiologically, we can put drain, sir. The patient abdomen is fine, patient vitals are fine.
See, I think duodenal stump bloat is a very significant emergency. I don't think radiologic drainage is going to help in that situation. So you have to, if at all you haven't put a drain, if you have already put a drain and if there is drain output, then you can obviously monitor, provided the patient is stable. The patient has to be, you have to, list what are the things you are going to do. Saurav, you're going to keep the patient nil by mouth. You have to consider the nutrition. You have to start them on total parenteral nutrition. You have to then make sure their fluid and electrolyte balance is looked after, and then and monitor the output on a day-to-day basis and see how patient is progressing. There is role for octreotide. Again, I think it's very sort of dicey or there is controversy, but if the patient responds, if there is good response in the first 24 to 48 hours after giving octreotide, you can continue. If there is no response, then the patient is unlikely to respond. You can stop that. You also have to give them high dose proton pump inhibitors, so to try and reduce the output of the duodenal stump. You have to ensure that there is no generalized peritonitis.
Yes.
So that is what Dr. Lakshman also has put up in the chat. So I think if patients respond with the first 24 to 48 hours with octreotide, then you are well within your this one to continue. And high dose PPIs, again, it will reduce the gastric gastrin induced pancreatic secretion as well. So it is very useful. So you should give them high dose PPIs. Keep them nil by mouth so that the oral intake induced gastric secretions will also come down. So these are, and then maintain their fluid and electrolyte balance and nutrition, and then hope that the fistula will heal. So if you haven't put a drain and if there is a duodenal stump blowout, I don't think going by radiologic drainage is going to be helpful. I think you have to do a relaparotomy, and then, as Saurav said, you should put a Foley's catheter and close the duodenum around that, and then also put drains and come out, and then manage the patients as we have detailed already.
Yes, sir. Instead of going back again, can we just put a drain and come out and see if at all it leaks, it will come out through this. So one procedure we can save.
See, that is the thing, so this is always a
surgeon preference.
This is always a problem. So, the thing is, the ERAS protocol and all these things say that you don't put drains and you manage these patients well. So in most circumstances, when it is working well, all these things will work. But in that odd patient where you haven't put a drain and if there is duodenal stump blowout, then there is a problem. So then you have to address it that way. when you actually, as the other thing is, if you are expecting a problem, then I think, as Dr. Shivaram has suggested, a preemptive, feeding jejunostomy can also be placed, which you can use it for a long time when the patient gets better. So that if you do that, then you can obviously avoid TPN. But if you haven't got a feeding jejunostomy, then you have to use TPN, or if you reoperate on this patient, then at that time you can put a feeding jejunostomy. Right. Any questions, Dr. Shivaram?
No, I will say like this: if there is a generalized peritonitis, requires re-laparotomy.
Yeah.
If it is a localized collection after the duodenal stump leak out, can be definitely manageable with the radiological intervention.
Yeah.
And also same time we can put a nasojejunal tube for feeding that can go beyond the anastomosis, and probably we may be able to feed also after a few days of TPN if it is required. Many times TPN and feeding jejunostomy both can go together also.
Yeah.
And then gradually we just stop the TPN.
TPN, yeah.
Yeah. All depends on the patient's situation, how it worsens or improves, like that.
Correct. Okay. Dr. Lakshman sir, any questions?
No, I think I agree with what Shivram has to say. Duodenal blowout and a duodenal leak are two different conditions technically. Yeah. Blowout means that there is a major leak, so there is no conservative treatment. Yeah. But if it's a small leak, if you have used a stapler or if you sutured it, if one stapler is gone or one suture has given way, then that will be a very localized kind of collection, as Shivaram has mentioned, and that can be managed conservatively.
Definitely.
But a blowout by definition is a major leak, and that will not close unless you go in and do a formal duodenal fistula.
So that is what, because Saurav said duodenal blowout. That is why I said you can't manage it conservatively. But if it is a duodenal fistula, definitely it can be managed conservatively. Vasant, any questions?
Sir, can I ask one? I want one clarification, sir, regarding immunotherapy. In textbooks, they have mentioned that it is given for stage 3 carcinoma with that PC Banil, some drug from.
I am not sure. I am not the right person. I don't know if anybody in the group are sort of big on immunotherapy. I think they are all, suffice it to say, they are all
newer
on trial basis.
Yes.
Trial basis when nothing else works. I don't know whether, if you are desperate, you can give it, but I am not sure whether it has a definitive role. I think even chemotherapy in gastric cancer, I think the role is improving, but certainly not yet, at the level of colon cancer, where the chemotherapy is excellent, actually.
Yes. And sir, radiotherapy for painful bone secondaries only. Otherwise, it has no role in.
No role. Yeah. Okay. So, right, Vasant, you want to ask any questions? Vasant, you're there? Right, we have come to around 10 o'clock. So it probably will be difficult to do another case. Dr. Lakshman sir?
I think we will end here. I think it has been a good discussion, and yeah, I think we will deal with the other case some other time.
Sir, is there anything you want to add to the whole discussion?
No, I think
or final closing comments.
Sir, right, 1 minute, sir, before we close, sir. I want one clarification.
Yeah.
Sir, that endoscopic mucosal resection, they say for tumor less than 2 centimeters, it is practiced in Japan.
Yeah.
So for tumor less than 2 centimeters, which is well differentiated, no nodal spread.
Yeah.
So is it practiced in India or?
See, it is practiced in India. See, the thing is, we don't see so many early gastric cancer. See, there are many things that are different from Japan too. See, first of all, the tumors, gastric cancer that are seen in the Orient, which is Japan and China and Vietnam and Korea, is a different animal compared to the rest of the gastric cancer that is seen in the rest of the world, Europe, India, and in America. That is definitely a case. Second thing is, because gastric cancer is so common in those countries, there is a very aggressive screening program which detects early gastric cancers, and hence they are also extremely skilled surgeons, and they are very good, very technically very gifted surgeons. So their operative technique is unquestionable, and hence they have very good results. But they're only in the early gastric cancer, you see 90 to 95% 5-year survival. Now, with regards to your question about endoscopic mucosal resection, yes, definitely. After evaluating the tumor with endosonography and CT scan, because even in early gastric cancer, there is a 5 to 13% chance of lymph nodal involvement. Even and the more so if it is a sessile lesion compared to a polypoid lesion. Again, polypoid lesion in stomach is much more uncommon compared to a sessile ulcerative lesion. So hence, the lymph nodal involvement can be in the range of 5 to 14%, which is why you have to be extremely careful when you do endoscopic mucosal resection. So provided you have all the proof that this is only a mucosal pathology without extra gastric spread and nodal spread, then you can certainly do a endoscopic mucosal resection and then follow up these patients very rigorously. Again, your question about whether it is practiced in India, it can be, it is being practiced in India, but you seldom pick up early gastric cancers in India.
Okay.
Dr. Shivram?
Sir, one more question, sir.
Yeah.
Sir, Dr. Shivram had also highlighted this fact, sir, indication for neoadjuvant chemotherapy in these cases, sir. So
Yeah.
what are the indications of neoadjuvant, sir? This is not clear for me, sir. I read, but I didn't understand when to give.
Okay. See the thing is, neoadjuvant chemo. I am not, because pardon my ignorance, but if at all, if there is anything that I say wrong, but neoadjuvant chemoradiation in stomach, then there are very good trials which show that there is benefit. But I think basically when for example it is considered to be non-resectable at the first instance, if there is significant
serosal involvement.
Serosal
involvement.
Serosal involvement, lymph node involvement, contiguous structure involvement. In such patients, you give neoadjuvant chemotherapy and then downstage the disease and then do the resection. But it is less effective compared to colonic cancers or rectal cancers, where that is a very accepted standard line of management. Dr. Lakshman, sir?
Yeah, I would agree. I agree with it. But the question comes, unless there is a clear-cut radiological evidence of adjacent structures which are involved, serosal involvement is very difficult to pick up only on radiology. And so
sometimes you may have to do a diagnostic laparoscopy.
Yes, that is, I was about to say that. One of the things, but of course, even if you do a diagnostic laparoscopy, you would not stop there just because you're not given neoadjuvant treatment if you detect a serosal involvement. And it is true that the neoadjuvant treatment is not as, that's why you're confused, Saurav. The world is confused, not just you.
Okay.
So,
okay, sir.
Yes, sir. The role of neoadjuvant treatment in gastric cancer is not as well established as it is in esophageal and colonic cancer. Okay, there is a question mark on both gastric and pancreatic cancers. It can be tried when there is an obvious extra gastric extension where you are not sure whether you can resect it or not. So give them a downstaging chemotherapy, neoadjuvant chemo, and then go in and operate. That would be the role. But as you said, clear-cut guidelines I have not seen for neoadjuvant treatment for CA stomach.
Okay, sir. Thank you, sir. Thank you.
But laparoscopy is very many centers practice because once their serosa involvement or lymph node involvements are there, the peritoneal metastasis rates are higher.
Very true.
It's always better to do laparoscopy and then do laparotomy, or if there are no metastasis, we can go ahead with laparotomy. This is practiced in most of the centers nowadays.
Yes, yes. I always put a laparoscope in, both for CA esophagus and CA stomach. Always do.
Lakshman sir, endoscopic mucosal resection, any more?
What you said was very correct. It is not difficult to do. It's easily done, but we don't see cases in that stage at all.
Yeah.
It is mostly picked up in high prevalence countries, as Ravi said, mostly through surveillance, not through symptoms. Okay, these are picked up before the patients develop
symptoms.
Symptoms, and so screening. When not surveillance is the wrong word. Screening. Picked up during screening. Yeah.
Or when you do endoscopy for something else and you see
incidental find.
Small
incidental. Yeah.
Correct.
Sir, one exam-oriented question, sir. Sir, there are lymph node stations, sir. There are around 18. So, do we have to remember that for exam, because it is difficult to remember?
I can't answer that question. I don't ask that. I don't remember it. So whatever I don't remember, I don't ask.
I think
you'll have to ask.
Examiners, I think they are fond of. So if you are being asked lymph node stations, then you are doing extremely well. So I don't think you need to worry. But I think lymph node stations, you just need to remember the salient. I think Manish Joshi, actually, I think we'll ask him to actually send it again. Manish Joshi had a very easy way of remembering the lymph node stations. I will talk to him and ask him to send that thing. So then you probably can remember. But I don't think you need to worry about lymph node stations. I don't think you will fail because you don't know it.
Okay, sir. Thank you, sir.
Shivram sir, what would you say?
Correct. Very, very true. Very true. Ravi, I just want to say this. Dr. Lakshman has also put, I think for postgraduates, it's always better to practice post-op rounds very, very systematically. That is asking for the complaints and take a detailed history. Then go to the general examination from head to toe, including all the things and the drains, Rice tube, everything. Then systemic examination, and then go into whatever investigations done that day or whatever is required like that. I think if they practice that, it becomes very easy to make rounds, even the quick rounds in the ward.
See, I think the SOAP regime, which I think we practice, everybody probably knows it, but it's an acronym for subjective, objective, assessment, and plan. So basically, you talk to the patient, you will know if the patient complained of pain yesterday and the pain is better today, then obviously is better. Then if he has other symptoms like nausea, something new has come up, you need to take it seriously. Any new symptoms or persistence of symptoms from the previous day, worsening of the symptoms. So subjective assessment, then objectively, as Dr. Shivram said, head to toe examination, vital parameters, brain output, urine output, and general assessment of the patient. And then you make a total assessment of the patient and then plan for that day. So that is the SOAP regime, which if you follow, generally you not usually be in the wrong. So I think we'll stop here.
If I may just jump in, sorry, just before you stop, I'm going to reiterate what you and Shivram have said. Time and again, we see postgraduates, when we ask them, what do you do? Like it happened today, he says, I look at the conscious status and then I look for rigidity and distension in the abdomen. Completely incorrect. In your mind, not only when you answer, when you go on rounds day to day, every single day of your life as a surgeon, you have to have a systematic approach to the patient. If you practice that in your life, when you answer also, the systematic answer comes automatically to your mind. So what it tells me when a postgraduate jumps from conscious status to the peripheral pulses to somebody's abdomen, tells me that he is not doing a systematic examination of his post-operative patients today. So please, all of you youngsters, learn every single time. Go in a systematic manner, see your patients, listen to their chest, check their calves, everything head to toe is a word that Shivram used. Please do it systematically and keep doing it all your life. And don't take cues from guys like Dr. Lakshman, who come and stand at the foot end of the bed and ask the patient, how are you doing? He says, fine, and he walks away. But he walks away at 65, 66 years of age. But at your age, he was doing exactly what I have asked you to do.
Correct.
I walk away today on the presumption that you have done a systematic examination. My junior has done a systematic examination.
Yeah.
If I have any doubt about that, I would do all the examination myself. So please make sure that that systematic approach is very important. I'm sorry I said this at length, but it does give me a little distress to know that systematically people are not approaching the care of their patients. It's very, very important. Thank you.
Yeah, I think you summed it up very well, sir. I think that is when ward rounds is an extremely critical component of not only the examination. Examination, as Dr. Lakshman says, is not important. If it is important to pass it, but to become a good surgeon, ward rounds, systematic ward rounds, thorough ward rounds is extremely important. So kindly develop that habit and make sure that you nail it completely so that you look after your patients well. You operate patients well, but you have to look after them better so that they get better sooner and leave the hospital a contented and healthy person. Okay, that's good night. Thank you.
Thank you.